So let me introduce myself. I'm Dr. Kevork Kazanjian. I'm one of the faculty members at UCLA. I work in Westwood, but last year I actually started coming out here 2 days a month to a clinic just down the block. So I have some presence at Santa Clarita, but I do all of my surgeries in Westwood. I'm the chief of colorectal surgery at UCLA, and March is Colorectal Cancer Awareness Month, and that's one of the impetus for doing this lecture today, and it's great to be here. So over the next several minutes, we're going to do a kind of an overview of colorectal cancer. And get some information and education about what it is and how do we prevent it, how do we treat it, and what the outlook is. So what is colorectal cancer? Like many cancers, colorectal cancer is when the normal cells of our intestinal lining, or our colon and rectum lining, loses its ability to control itself and starts growing into a tumor such as here, and likewise this here. So these are the normal intestinal linings, the opening of the bowel, and you can see the tumor. And when the tumor grows out of control, it eventually will spread to lymph nodes. So for example, with the tumor being here in the sigmoid colon, this is a diagram of the colon here, it can spread into lymph nodes, and then beyond that to the liver or lungs. It can even go to a place like the brain. And so that's what we are always trying to avoid from happening. And so it's a very serious problem. And how does it all occur? There is a well-described adenocarcinoma sequence that we talk about in a lot of cancers, and particularly in colorectal cancer. And what that involves is that you can have normal intestinal lining of the colon and rectum that, through a variety of genetic alterations, not necessarily inherited alterations, but damage caused to the regulatory system of our body cells, can develop these polyps that then, with additional hits, so to speak, to the genetic repair mechanisms of the cell, can proliferate into a tumor and grow through the bowel wall and spread beyond. And in this diagram here, it shows, this is an endoscopic view of the inside of the colon with a fiber optic camera. And this is normal, and here you can see a small polyp getting bigger, and then eventually to a cancer such as this. That's the normal kind of progression of how this usually occurs. And it's important to note that this does not happen overnight. This progression is actually over a period of up to 10 to 15 years. And so we have opportunities here to catch these lesions in the earlier form before it gets to this. We'll go over some statistics, and the current anticipated new cases of colorectal cancer is about 135,000 in the US in 2016. That places it at a rank of number 3 among all cancers, combining both men and women. About 95,000 of these are colon cancer, and about 40,000 or so is rectal cancer. We lump them together as colorectal cancer, but the reality is that there are differences as well between the colon versus the rectum. And combining both the colon and rectum, close to 50,000 Americans will die in 2016 as a result. There's about a 5% lifetime risk for an average American to develop colorectal cancer in their lifetime. And as stated, colon cancer is not interchangeable with rectal cancer, as rectal cancer can have a propensity to have local recurrence, and as such, there are significant differences in how we treat rectal cancer versus colon cancer, even though the underlying biologies can often be very similar. Some good news is that the incidence of colorectal cancer in the United States is decreasing. The statistics from 2006 to 2010 indicate that the incidence has gone down by 3.7% per year for individuals over the age of 50. Okay? That's without doubt in large part due to the screening programs that we have for early detection and catching early colon polyps before they become cancer. Likewise, the mortality or the causes or death from colorectal cancer has also been going down about 2.7% per year over this time period. And that likewise is related to early detection. So even if it is colon cancer, we're hoping to catch them earlier and as a result have better longevity and survival, as well as the better treatments that we have nowadays. Now, the not so good news is that in the younger population, it's actually rising. About 1.8% per year rising incidence of colorectal cancer. That means that of the 135,000 new cases that I was referring to in 2016, 13,000 of them will be in individuals who are younger than 50 years of age. And we don't fully understand why that is the case. Why is the incidence in younger folks going up? There are some theories, such as, for example, the higher propensity of obesity and diabetes in younger individuals leads to the higher risk of development of colorectal cancer. That's one possible hypothesis. Another is that as we are catching more of the cancers early in older patients, perhaps the proportion of younger patients is becoming skewed as well. And so as a result of all this, it is the second leading cause of cancer death in the US. Only lung cancer tops colorectal cancer. Okay? So it kills more people than breast cancer, kills more people than prostate cancer, and kills more people than pancreatic cancer. So it is a big burden. And worldwide, just like the incidence is going up in younger folks, worldwide the incidence is increasing. And for example, in China, there was a study last year that indicated that the rate of colon cancer is skyrocketing. And in the year 2011, there were 310,000 Chinese diagnoses of colorectal cancer, making it the fourth most common cancer there. And about 100,000 more Chinese died from colon cancer than in the US back in 2011, making it the fifth ranking cancer killer. And it's interesting that if you look at who is being impacted more, you find that urban men are the biggest victims, followed by urban women compared to rural populations. What that tells us is that in countries that are developing, such as China, Russia, they're catching up to our American bad habits, and their rates of colon cancer are going up. Part of that may also be that they're also advancing in diagnosing and catching the colon cancers with their improvement in medical care. So what are the risks of colorectal cancer? This is obviously a very important slide for, for prevention of colorectal cancer. And I've listed here two columns, what increases the risks and what decreases the risks. So the things that increase risks are age, male gender, family history, Western society, what we talked about with the US versus China, for example, alcohol, obesity, smoking. Inflammatory bowel disease includes things like ulcerative colitis and Crohn's disease. And dietary fat, red processed meats. You've heard all this before. This is all the obvious things that we're told to do and not do. On the things that reduce the risk of colorectal cancer, calcium, so dairy products, folate, things like aspirin and anti-inflammatory medications, exercise, fruits and vegetables, and dietary fiber. These are the things that have been linked to lower risks of colorectal cancer. So how do we prevent, how do we lead to prevention of colorectal cancer? Well, there are some things on this list that we can control, and others like age, gender, and who your relatives are that we can't control, right? So if you try to focus on some of the things that we have control over, then we could potentially have an impact. But it is not infrequent for me to meet a patient who has just been diagnosed with a colon cancer that I need to take care of, who is a vegan, a marathon runner, and has done everything that they're supposed to have done to not get it. So there is no, despite all of that, there is not a silver bullet that makes us immune from developing colon cancer, but there are things that we can do to reduce the chances. The majority of colorectal cancers can be prevented with screening. Not all, but the majority, by finding early colon polyps and addressing them in that form as opposed to cancer. And with colon cancer screening for average risk adults, and what we mean by that is those folks who do not have a substantial family history of colon cancer, then the screening should begin at the age of 50. If an individual has a strong family history of colorectal cancer, then we usually will begin the screening process 10 years before the age of whoever they had in their immediate family that developed colon cancer. So if my mom had colon cancer at the age of 65, then I'm still considered fairly average risk. I would still start my screening at the age of 50. If my mom had colon cancer at the age of 55, I would start the process at age 45 instead of 50. Okay. So, and in some of those situations, the genetic counseling may be of benefit when there seems to be a predilection in the family for colorectal cancers. And most colorectal cancers are not linked to any family history at all. So, 80% of folks who develop colorectal cancer are not going to be able to pinpoint any kind of a relationship to any family history. So, so the typical adage of, but nobody in my family has ever had colon cancer, how can I get it? Well, that's true for 80% of folks who do get colorectal cancer. So what are the screening tests that we subscribe to? There are a number of them, and they all have their pros and cons and strengths and weaknesses. These top three tests here, fecal occult bulk test, FIT test, stool DNA test, these are things that can only detect colon cancer if you already have colon cancer. They're not going to detect colon polyps typically. Okay? A sigmoidoscopy is one where the camera is inserted into the colon, but only the left side of the colon. And it can find cancers and polyps on the left side of the colon, but it is not examining the entire colon. And so if there is something that's identified on in the left side of the colon, then one must proceed to a complete colonoscopy. A colonoscopy, a full colonoscopy is the best test to both identify cancer and early polyps, and as well as at the same time, whenever possible with polyps, to remove them. A barium enema is an X-ray study. It's only going to identify larger tumors. And finally, CT colonography is one where it can identify polyps as well as cancer, but it has a limit to the size of what it can identify. And if you find something, you can't do anything about it. You can't biopsy it, you can't pluck it out. The attractiveness of CT colonography is that you're not having a camera inserted in your colon. But otherwise, you're still going to need to do the bowel prep to cleanse the colon, just like you would with a colonoscopy. And everyone says that, all patients say that the worst part of it is the cleansing, and not the actual colonoscopy procedure. And so what would I have for myself and my family members? A colonoscopy, and nothing really short of that. So how does that work? The way that a colonoscopy works is that you have your endoscopist and an assistant. You lie down on your left side. You've taken your cleansing solutions the day before, and a fiber optic camera with a monitor is introduced into the colon. That begins down in the rectum, and it gets advanced all the way around to the beginning of where the colon starts, which is the cecum. This is where the small intestine is going into the cecum. Here's the appendix. And once we get to this beginning, then we start backing out and looking along the way at the intestine, the mucosal lining of the colon, looking for polyps, for cancer. And if there are small polyps, we can remove them with the colonoscope at the same time. And this is a picture of what the inside of the colon looks like with the camera coming out towards us. So that's how it's done. It is safe. The most challenging part, again, is the cleansing. So what do we see on colonoscopies? I'll show you some pictures of little polyps. So, we don't know if this will ever become a cancer, but it may. And so what we can do is the same thing here, a little polyp here. This is all normal. And then you can see these little lumps here. And then a little instrument can be placed right through the colonoscope, and that little guy is plucked off. And you can see the residual of where that is. On the flip side here, this is what colon cancer looks like. And then that as well. And then what we do here is, again, introduce a little biopsy forceps. We can't remove this entire thing. We just take a biopsy, and then these patients move on to surgery that we'll talk a little bit about. What are the signs and symptoms of colorectal cancer? These are the kinds of things that we tell patients to watch out for. Changes in bowel habits. So, for example, you develop a different pattern than your usual that sticks around for a couple of weeks, such as diarrhea, constipation, or a narrowing of the stool. We call it a pencil-thin stool. It feels like a stringy stool is coming out instead of your normal stool. A feeling of incomplete emptying after the bowel movement. You have a bowel movement, but then you feel like there's still something there. Rectal bleeding, crampy abdominal pain, weakness and fatigue, which can indicate anemia, or in general, if you go to the doctor and get your blood test done and you turn out that you're anemic, that could be a potential concern. And unintended weight loss. Okay, those are all potential signs and symptoms of colorectal cancer, but it can be present without any symptoms at all. And finally, if you have any of these, it doesn't mean that you have colorectal cancer. So most of the time, it turns out that it is something other than colorectal cancer. But these are the things to kind of keep in mind. A lot of times rectal bleeding can be related to hemorrhoids, for example. However, one of the dangers that I often encounter is that it is assumed that, oh, it must be your hemorrhoids, but then it turns out that it's cancer. So the reverse can bite you as well. How do we stage colon and rectal cancer, and what are our 5-year survival rates? We call this the T&M staging system. The T stands for how deep in the bowel wall the tumor goes. Okay, so this is the bowel wall lining, and we assess according to the layers that the cancer is involving the T stage. The N stands for nodes, so depending on whether there's any spread to the lymph nodes or not. And the M stands for metastasis, spread to other organs, such as the liver. So this is actually a CAT scan showing cancer spread, colon cancer spread throughout the liver. This is what we want to avoid, okay? So if you look at the different stages, we have 4 stages, but then each stage is further broken up into sub-stages. And we can see that if for a stage 1 colon cancer treated with surgery, 5-year survival, 92%, okay? And then with stage 2, we drop down a bit depending on the specifics of the T component of the stage. And then stage 3 is when we have lymph node involvement. And depending on the number of lymph nodes as well as the depth of the tumor, we can have a 5-year survival. This is with the addition of chemotherapy of almost 90%, but depending on some of the other details, it can drop down to 69, 53%. So it's all things considered. There's a lot of hope in this, but then there's a lot of negative results as well. Finally, with stage 4, meaning that spread to organs such as the liver and the lungs, which are the most common places that colorectal cancer metastasizes to, the survival rates are not as good, but this is at 5 years. So that tells us that there are a lot of patients with stage 4 that we continue to treat and we can even potentially cure. And so stage 4 doesn't automatically, determine a death sentence or untreatable, for example. We do a lot of that. So how do we treat colorectal cancer? There's actually been significant progress over the past 20 years in multimodality therapy and refined surgical techniques when it comes to treating colorectal cancer. What do I mean by that? It's a combination. Multimodality means a combination of different types of treatments. And in colorectal cancer, we use surgery, which is the mainstay, chemotherapy, and for rectal cancer, radiation therapy. And it's not one versus the other. They work in synchrony. And that's how we're able to achieve the better results that we have experienced. Currently, cure from colorectal cancer is rarely possible without surgery. And then depending on the stage of the cancer, 1, 2, 3, 4, the role of chemotherapy comes in, which can then reduce the risk of recurrence of the cancer by about 20%. And the good news is that, when patients ask me, well, if I need to have chemotherapy, am I going to lose my hair? Am I going to have this and that? There are so many different kinds of chemotherapies out there. Unfortunately, with colorectal cancer, most of the side effects of chemotherapy, and there are side effects for sure, no question about it, they are reasonably well tolerated by most patients. And finally, I want to emphasize that multidisciplinary treatment planning helps ensure that we are providing the complete treatment plan for our colorectal cancer patients, because it's not just the surgeon, it's not just the oncologist, it's not just when we work as a team, we're able to provide the best treatment plans. And for example, these are the NCCN, or National Comprehensive Cancer Network, guidelines for colon cancer treatment. Okay, so what it involves is when a patient has the diagnosis of colon cancer, there's a list of things that need to be done in order to further characterize the condition and come up with a treatment plan. We have to look at the pathology, colonoscopy specifics, lab tests. We do a CAT scan of the chest, abdomen, pelvis to look for any spread of the disease. And after all this information is obtained, we proceed with surgical resection. The surgery has to be done properly, obtaining at least 12 lymph nodes to evaluate the stage of the cancer. And then once we figure out the stage, so for example, if it turns out to be stage 1, then no further treatment is recommended. If it's a stage 2, but with some high-risk features, we recommend that the patient undergo adjuvant chemotherapy, meaning that chemotherapy after the surgery. And if a patient has stage 3 colon cancer, which is highlighted by the presence of metastasis to lymph nodes, then it is also recommended that the patient have chemotherapy. On the other hand, if the patient at diagnosis has metastatic disease, meaning that tumor in the liver or the lungs, then what we assess for is, can all of that also come out at the same time? If it can, then at UCLA, that's what our preferred approach is, to go ahead and remove both the primary tumor as well as the metastatic tumor at the same time. If it turns out that it is not resectable at the time of diagnosis, then we treat with chemotherapy first and then reassess, because a lot of times when the chemotherapy is given, the tumors shrink and what used to be not resectable becomes resectable, and then we proceed accordingly. And if the tumors are resectable up front and we perform that kind of surgery, then after the patient is recovered from the surgery, we proceed with chemotherapy afterwards. When it's rectal cancer, it gets even more complicated, because the difference between rectal cancer and colon cancer needs us to evaluate the tumor, to stage it before the surgery with things like ultrasounds and MRIs. And if we believe that a rectal cancer is stage 2 or 3, we will actually treat with chemotherapy and radiation before any kind of surgery. And then after the surgery is done, we treat with additional chemotherapy. And so as you can see, all of these different tests and convoluted decision pathways requires a multiple number of doctors, and we strongly believe that a team approach is going to be very important. That's why at UCLA we do have a colorectal cancer treatment program with a team that meets every week to put together a plan for all of our new cancer patients. We have the surgeons, the oncologists, the radiation doctors, radiologists, liver surgeon, and the most important person is our nurse navigator, and our geneticist, for example. So the principle, I'm a surgeon, so that's my area of expertise in that team, and what we do with the surgery is that we remove the anatomic segment of the colon along with the lymph nodes that are involved in the region of the colon that is affected. Fortunately, in colon cancer, a colostomy or a permanent colostomy is rarely required. In rectal cancer, occasionally it is, particularly when the cancer involves the actual exit or the sphincter muscles, as well as in some patients who at baseline have incontinence, so if they can't control their stool, even before any kind of surgery, it's probably going to get worse afterwards. And so in some situations, it's better to do a colostomy as opposed to rendering them completely incontinent. But in most situations, it is something that is avoidable. In patients with rectal cancer, a temporary ileostomy is something that is commonly recommended because it serves as a bridge to sphincter preservation. So we use a temporary ileostomy to allow a particular area that we reconnect back together to heal, and then a second smaller surgery comes down the road to rid the patient of the ileostomy bag. And most of the colon and rectal cancer operations can be done in a minimally invasive fashion. What we mean by that is a laparoscopic or robotic approach. But this does require a high level of skill, and it is not always available at everywhere. The benefits of a minimally invasive approach would be that the patient will have less pain after surgery, a quicker return to activities, shorter length of hospital stay, and improved cosmesis. But oftentimes it's